Hello, good evening. Hi, Nick.
Hello, Dr. Rana.
Yes, let me turn the camera on. Hello. Hi,
Hey,
good to see you, friend.
good. How are you guys?
We're wonderful. Very happy to get in touch and for you and Dr. Rana to get acquainted and just exchange thoughts on philosophies and yeah, possible collaboration.
Yeah, I love it. Awesome. No, that's great. Well, yeah, Dr. Rana, I've heard so many good things about you. Look at your
Same
smile.
here, same here. Lovely things I've heard about you as well. So nice to connect personally again.
Absolutely. And so tell me, what's your schedule tonight? What time, how much time do you have this evening?
Between happy hour and 8.
Yeah.
I'm available to discuss at least an hour or more if needed. That's totally fine.
Okay. Because I mean, I just love I want to know your experience in the Tony world and
That's true.
everything there. I want to I mean, yeah, I'd love to hear about all that and your personal journey in life, and then we could talk about airway. I'm interested in everything,
How sweet.
but yeah, we have three or four or five patients that are down in Sacramento area that would love to come in and do a collaboration and I would love to share with you what we're doing and I'd love to hear your journey so far and compare notes.
Absolutely.
So, but yeah, I've got about an hour as well and I could take more if needed, but but I want to be mindful, it's coming up on the holidays and stuff, so.
That's fine. I appreciate that. I did have a pleasure to meet Chloe and her mom today. They already came in this morning. And Chloe is about 6 years old, very
Okay.
sweet girl. They came to me under the impression that you already have collaborated with me and you are already going to make an appliance for her, and I will be delivering it here.
Are you? Oh my goodness. Oh my goodness. Are you kidding? What's their last names?
Let me see. Chloe, uh,
Oh yeah. Okay, gotcha.
Gulebemko.
Yeah, there we go.
Yes,
Okay, this is okay. All right, let's see. Oh wow. Okay. So yeah, I've never seen the family. They've never been to my office. They
I
wanted
see.
to come to my office, and I think there might have been a misunderstanding because I asked them to reach out and check with you and say, hey, I have a meeting with them. See, when they called in, they were supposed to ask, do you want me to come in before or after the meeting so we could discuss the case or whatever? So,
I see. So basically, she said that her somebody in her family, I think her sister or somebody, and their kids are already being treated by you or have already been treated by you, and they are very happy with the outcome. Um, she speaks very highly of you. She does not mind going to Oregon all the way and have you treat her daughter. And she still is very much intrigued by the appliance that you are using for expansion, the removable appliance. Apparently, it looks like she has already seen her family's kids being treated with that, and
um,
she really likes that idea, and she was under the impression that you already have talked to me and we are going to be working here on your behalf. And I said, in orthodontics, it doesn't work that way. You usually have to go to the doctor and they are the one going to do it. What I can tell you how I treat patients here in this kind of situation, and kind of give you my treatment plan on how I would approach it. I told her that I'm going to be collaborating with you tonight. I'm going to have a meeting with you and discuss the case tonight. And then once I kind of we both get our heads together, we can come up with a plan, and then I will reach out to her again.
Oh, beautiful. Yeah, that's beautiful.
So she is basically a crossbite case, um, unilateral posterior crossbite. She still is in primary dentition. Her lower incisors are the two central incisors are erupted, but everything else is still in primary dentition. She did lose her upper primary incisors. So I really didn't know what the overjet looks like, but it almost looks like more edge on than an anterior crossbite to me. But once the permanent incisors come in, we can tell what kind of like anterior relationship she will be building. Looking at her itero skin, I could tell that she does have definitely the narrow maxilla. Whenever I see that in conjunction with crossbite and anterior or posterior, I am recommending rapid palatal expander. I do the bonded RPE where I put a like a acrylic pad on the occlusal surfaces of the teeth, disclude the teeth, and then based on the measurement that I make, I decide how many millimeter of expansion I want to create. And then we do the expansion with the rapid palatal expander. And then if there is an anterior crossbite in conjunction with it, then I do recommend doing the reverse full headgear that they wear it at night time only. And then that first 6 to 8 months is basically with that appliance. And our goal is to get the maxillary expansion, get the crossbite out of the way, and correct the anterior crossbite. And then once that is taken care of, then I do the rest of the correction with aligners, with the Invisalign first appliance. But
Yeah.
I do want to know your treatment philosophy as well, like airway geared. I mean, we are trying to get the forward growth by expansion, like transverse, of course, but with the reverse full headgear, we are trying to protract the maxilla forward. And then as maxilla comes forward, the mandible will follow it. So that's how I normally plan it. She loves the idea of removable appliance, and she is very much liking your treatment philosophy. So I said maybe we can collaborate in that way. Maybe you go in and do the initial phase of expansion with the. I would like to know more about your appliance and see how you are treating this kind of cases. And then maybe later on, when it comes to aligning the teeth, if you need my help, I can get in there and help her with the alignment treatment.
Okay, Dr. You are so sweet. I am
I
sorry
told
they were
you.
so I'm sorry they were so presumptive. Like there's a little miscommunication. They went a few steps ahead, and I think that must be a cultural thing, or they're trying to. I'm guessing, I don't know, like, but they may be trying to push for their agenda or what they want. So I'm
Yes.
to have you in that position. And bless you. Thank you for being so kind and open and navigating so gracefully, huh, Kat?
Oh,
Oh my
that's so
goodness.
kind of you. Yeah,
So,
no, she came in very strong in the way that she wants to be treated like how you would plan the treatment. And I said I totally respect that, but I don't know Dr. Tanner's treatment philosophy yet. So let me look into that. I'm always open to learn, and then we can figure things out for her.
yeah, yeah, beautiful. No, that's great. That's great. So tell me, I want to understand what's your journey in airway? What have you done? What have you learned? What systems have you worked with? What's been your training and stuff that way?
I'm very new with the airway. Main thing I'm trying to learn. So my ortho journey started with progressive orthodontics. Back in 2014 and 15, I did their 2 years of comprehensive course of orthodontics. I learned everything about ortho, like how like an orthodontist would be going through their journey. So starting from diagnosis, treatment planning, learning all the case types, face types, cephalometrics, how to read it for the growing patients, how to use the growth trajectory and know like if we're dealing with class 2 cases how important that differential horizontal growth is, where you are getting the forward movement of the mandible and get a lot of class 2 correction. In class 3 cases how important it is to start very early and try to get them out of that cross bite, expand them as needed so that we are creating room for the tongue and also you're opening up the airway. Um, I haven't used very many airway appliances. That's where I'm actually very excited to meet you today and see like what the airway journey like. What would be my journey like in order to expand my skills into becoming an airway ortho, or orthodontist, where right now I'm expanding their arches with aligners and I'm seeing beautiful alignment, nice parabolic arch developments. And the way I try to to prepare my cases is I'm not pushing anything back, less IPR as possible unless there is a lot of stress in the tissue here where the tissue type is so thin, the biotype is very thin, there is recession involved already, where I don't have enough room to unravel all this crowding and I'm kind of stressing the tissue. Those are the times in adults where I would do some IPR, but most of the cases my goal is to create some like transverse expansion, develop the arch form, and as I develop the arch form I do see them like like oh my gosh, I feel like I have more room for tongue now, I'm able to breathe better, things like that. So my journey for airway is mostly I'm creating the arch development, like molars are usually mesially in, like they are literally linked, like rotated towards the mesial. So that is like my anchor spot. I'll distal rotate the molars and that becomes my beautiful reference. And then I do the rest of the arch development, keeping the molars in the reference. And that is how I treat most of my arch development cases with aligners. In kids, I'm normally using expander for the expansion and then try to guide the growth forward. But other than that, I would love to know more about airway and how other appliances or other treatment modalities out there that would help me grow in that journey.
Yeah, wonderful. I love that. Bless you. And what was it that got you interested in moving towards airway?
As I see more and more patients that were treated in the past, long time ago, having premolar extractions, bicuspid extractions, and such narrow arches, right? And those patients that were treated in the past by whoever orthodontists were, now I'm seeing them with airway obstruction. They are being diagnosed with sleep apnea and I'm treating all these kids. And back in 2014 when I did my ortho classes with orthodontics, premolar extractions were a thing even then. If there is not enough room, remove bicuspids, and treat the case. So that is when I started to realize, I'm like, no, there has to be a better way. This is not the answer. And we are not paying attention to like what happens after. You got the straight teeth, but then what happens to the face in general? There is no attention being paid to that. And that's when I started just like researching more and more into the clinical education with aligners. And then I'm so thankful to be coming in contact with this one clinician. His name is Dr. Terry Cuddington. He's a very good name with Invisalign. And I started attending his courses, and his like he is the one who really opened up my eyes and like taught me what you can achieve with aligners. I didn't believe in aligners until then, but the like with the proper case planning, biomechanics, by placing attachments, the right attachments in the right position, like how you can actually like guide the teeth with the forces, like gentle forces with aligners, and create the arch form. And when he was presenting his cases, I'm like, oh my gosh, I can't believe these cases are being treated with aligners. It changes the whole face, like all these narrow arches are like now being treated, and like there is like more fullness, all the buccal corridors are filled. Patients are like reverse dolicho effect we are getting, like all the like downward and vertical growers by like auto derotating, auto like
Counterclockwise
anti-clockwise
rotation.
movement of the mandible. We are turning all the dolichofacials into almost like a mesofacial type. So when I saw all that happening, and it's merely being done with aligners, especially the open bite cases, they were beautifully turning out with myofunctional therapy and everything. So I started taking his courses more and more and more. And now pretty much every case I treat with most of the like appliances in the beginning if they are the growing kids, and then putting them into aligners, and with the adults mainly aligners. But
Wow.
now I want to do like more of like the airway assessment. How do I incorporate like airway into this, and more focus towards airway. I know
Hmm.
that I'm treating airway already, but I'm not calling it as that. But now I want to kind of focus more on that.
Yeah, yeah, no, that's great. I love that. That's wonderful. Well, let me tell you my journey a little bit, and then I'll show you some case examples. I don't know if you saw my brochure or looked at my website at all, or
I briefly did, yes.
okay.
Yes.
So, yeah, I got out of dental school in 2007, and my first mentor said, anyone doing airway is like scamming people. You can't do anything with sleeper airway. That's the medical doctors. And then my grandpa died from sleep apnea. And
Oh,
so that got me really curious and interested. And so I started taking courses in 2010 doing the adult sleep appliances. And then I became one of the first MyoBrace certified providers in North America. And then I did ALF, Crozets, orthotropics, braces, pretty much every system, Healthy Start, Vivos. I worked with pretty much every system out there. I've done MARPEs,
okay.
MS, surgical, all that stuff. And just have realized like we need more tongue space, and it's good for the
Exactly.
TMJ and all the connections. And so just and working with all these different systems and appliances, I found good things and limitations and kind of combined things into like an airway appliance that we use. I've had patients from 20 states and 4 countries come to Southern Oregon to use it. And
Amazing.
now, like, we'll take local patients, but anyone out of the area, I'm trying to train dentists across the country to do this kind of treatment because I feel like it's the best airway treatment that people can get. And Oregon's a big premolar extraction state. It's common. And so like there's a patient who came to me that went to an orthodontist who on their website and all their marketing is all airway orthodontics. And the doctor recommended 4 premolar extractions and said, we're going to open your airway. And the patient did that and started going through and just got more uncomfortable and didn't like what was going on and came to me and said, the orthodontist gave me so much reassurance. They were opening their airway. I trusted them. I believed them all along the way. And now they're saying, the orthodontist is saying they can reverse it. And it's like, well, if they really know how to reverse it, they wouldn't have done it in the first place.
Mhm.
But that's one of the things that said I need to teach this because everyone's talking about the same things, everyone's saying the same things, but everybody is not delivering the same results.
Correct.
So whether you're taking out premolars or not taking out premolars, it's whoever has the best marketing that the people believe. But they
Mhm.
don't find out later in life that what actually happened to them may not have been the best thing for them.
Correct.
So that's what I want to do. Hopefully I can share some things, but from my
Yes.
heart, like my goal is to convince you that this is a new thing. There's value in trying this approach and using some patients. And you have some patients that are interested in being guinea pigs in your office, kind of trying this out. And a lot of in fact, I just met with an orthodontist in Idaho,
Uh-huh.
and he just gave me a great video testimonial. But he's a dual trained pediatric dentist orthodontist, and he used my appliance for his son who had a crossbite situation in the all primary dentition. And now he's doing a lot of patients, and he's been doing cases for 6 months now or something. And I just went to Idaho and met with him just last week. And he said, okay, now how much do you charge? And I'm just like, what? Like, you're not charging your patients?
Oh
He's
my
like,
God.
no, because like I didn't know what to charge and I'm just experimenting on them. I didn't know if it would really work or not, but I want to start charging for this. I want to start doing more of these. This is good. I want to get like a system like what do you charge, right? And I'm just like, okay, you need to be charging from the beginning, okay,
Mhm.
don't charge your son, fine, but
Surgeons
but
don't.
all of your other patients, like I just like had no idea he's like doing all these cases and not charging them because he wanted to see how it works.
That's
But
amazing.
like like if you want to see his video, I'll show you his video. But you should be charging from the very first patient
Correct.
because this is going to take your time, this is going to take your energy. But a lot of dentists, what's common is they don't really charge their first few cases
Mhm.
because they feel like they're learning. But it's like the
Mhm.
patient is getting value out of this.
Yes,
I mean,
absolutely.
so much value, they want to come to Oregon, and I'm turning them away, saying, don't come to Oregon, right?
Right.
Like, they'll come to Oregon, I'm going to charge them, don't do them for free.
Sure. No, I
You know what
agree.
I'm saying?
I will make sure of it.
Yeah, she'll make sure of it. I would have done free. She knows that.
Okay. But
But
yeah,
no, I
they
agree.
are
When
not
I
going to be patient. I'm not going to see them. I go up to Eugene and I'm working with an office in Eugene, and the dentist is like, how are you going to be compensated? I want to pay you. And I'm like, no, I'm like, all the patients are paying you. You're getting the money. It's a startup practice from this wonderful dentist. And it's like, you need the money. You're doing a startup. You're getting on your feet. You're getting like, I'm going to charge you a lab fee, same as I charge everybody, but I want to help you. If you see the value in this and your patients are liking this, I want you to be a resource for people in the community that don't have this option available.
Yeah, absolutely. Yes, I would like to learn more about this appliance stuff.
So what is the appliance called, Nate?
It's called the Tanner Airway Appliance.
Okay.
Yay.
So
Okay.
did you say that there is a lab fee? Like, do you fabricate the appliance or do you work with a lab that is trained to fabricate that?
So I started making this in my garage.
Okay.
Wow. How sweet.
And because like I was just trying different things and you know, and I found something that was working. And then I got busy with it and I couldn't keep up with it. It was too much nights and weekends. So I got a friend of mine and I trained him and he started making it. And then now we have an official lab with 5 lab technicians who all make appliances and we ship them all over the world.
Amazing. Nice. That's
Yeah,
great.
so we check them, we quality control check them, we customize them, but it's, it's a good system and it's a good, appliance to use. So,
So,
yeah.
question for you. Just, I told you I have no background in ortho or airway, but I do want to be like in the loop. So, is the appliance something that you use at a very early age, or is that something you can implement with adults as well? Can you tell me more? Like, use basic English with me. I don't speak your ortho things, okay?
My youngest patient is age 2,
Okay,
although you could do a 1-year-old
okay,
if they're really desperate.
okay.
So
And then adulthood, is there a limit, or can you use it with adults?
the oldest patient I've done is 82.
Okay.
Oh, wow. Nice.
But adults need healthy teeth.
Mm-hmm.
If they're missing too many teeth, there may be limitations. If they have too much periodontal gum disease,
Yeah.
that's not a good
Yeah.
Mm-hmm.
thing to treat. But
Okay.
yeah, in fact, I'll show you some examples of children and adults.
So is that
Yes.
something that you will be like, you will be able to use alongside with aligners, or is that coming
Yeah, it will be in
before?
the early stages
Okay.
when we notice like a lot of like narrow arches. So I would like to know like what are your like parameters or criterias to put the people in this kind of appliances? Like what are the things that you are looking for early in that age when you make the
And it's
decision?
age at the 2-year-old mark.
Mm-hmm.
Sleep issues.
Sleep issues, I see. Got you. And like, do you do OSA screening for them on all of them?
Um, no, no,
No? Okay.
no.
So,
I mean, we can refer for an overnight sleep test. That's primarily just, in my experience, that's to get medical insurance. So they need the OSA diagnosis to have medical insurance cover the tonsil adenoid removal.
I see. I see.
And the kids I've treated, they went to get the tonsil adenoids removed, but they weren't even enlarged or they weren't enlarged enough, and they would refuse to remove them.
Correct. That's what I'm seeing more and more with ENTs, right? That right now there is a trend of not removing too many tonsils, at least, is what I'm noticing. So then how do you jump the hoop on that?
So we start developing their jaws.
I see.
I'm not treating the sleep apnea. I'm treating the oral contribution
Absolutely.
to the sleep, which is the underdeveloped jaws.
Got you. I see. Oh, yeah.
We're still in this. We like the oral contribution.
Oral
Yeah,
contribution to sleep, which is underdeveloped jaws.
yes,
Wonderful.
yes,
So is it.
Thank you.
yeah. Because we're not
Yeah.
medical doctors, we're dentists, but we're
Hmm.
helping the jaws, which is a contributing factor.
Absolutely. Absolutely. Yeah,
Mhm.
they somehow do not see that connection. I have really hard time
Mhm.
connecting those dots with the patients. Um, that how a narrow jaw or narrow maxilla with that V-shaped palate can like affect their airway and sleep and all of that. And
Mhm.
um, yeah, it's a movement I think we are all in right now. Like we are not just dentists. Like we are looking beyond teeth and cavities and um, just drilling and filling dentistry.
Yeah, right, absolutely. Yep.
Nate, do you currently do still general dentistry or is your focus mostly on ortho and airway?
I do general dentistry and then I also train on airway and ortho.
Okay. Something I really would like to understand is how much commonality there is in like philosophies, treating philosophies, especially if we will be, possibly exchanging patients because we also have patients out of state or some are moving. So we want to just make sure that we think similarly. Because it's like you go to 10 dentists, you hear 20 different opinions, and the patient
Right.
is more confused than before they came in. So what is like where do you stand on that? Or as much as we can clear that because we
What's
just
that? Tell me on what specifically?
um just overall approach and maybe it's not a one sentence answer,
In
but
dentistry or orthodontics?
both.
Both. So in dentistry, the less I drill on a person's teeth, the better for the teeth, unless it's really necessary. I'm
Mm-hmm.
fairly conservative. When I got out of dental school, my first mentor said, if you want to make a lot of money, tell everybody with a cracked tooth they need a crown. Try to do 2 crowns a day. And I stopped doing crowns completely. I turned totally away. I was just turned off by that completely. I said, you don't need a crown unless your tooth breaks. If your tooth breaks, let's do a crown. So after 1 year of doing that, I had 2 patients come in within a couple months. One had a vertical root fracture that had to get the tooth pulled. Another one cracked into the nerve and needed a root canal and a crown. Both of those patients looked me in the eye and said, Dr. Tanner, is there any way this could have been avoided? And I said, yeah, if we would have done your crown sooner before the crack went this deep. So those 2 patients kind of made me come back to the middle of the road where if I see cracks, I tell people, hey, you have a crack on this tooth. If you want to be proactive and prevent a future crack break on it, we can do a crown now. It may or may not ever break. You know, if it has symptoms, if it starts getting symptoms, it's higher risk of needing a root canal or needing to get extracted. What would you like to do? Would you like to wait and see, or would you like to do a crown? So now I give people the option and let them kind of decide. On cavities, I found like iodine. So on a personal note, like we don't do fluoride in my practice. I don't know if you guys do fluoride.
We do.
We do.
Do fluoride. So, like, I had a patient tell me the dangers of fluoride, and a patient gave me the book, The Fluoride Deception, and I read the book, and it was all about the toxic effect of fluoride on our bodies. And so I took it to a dental meeting and took it to the president of the dental association and shared the book. And they said, thank you. You're so conscientious. Thank you so much. But we're funded by Crest and Colgate, so we need to support them. And I was just kind of like surprised by that. But fluoride is really toxic to our brains and our organs, and it's not healthy for any of our bodies systemically, but it is good for the teeth. So something like we're painting fluoride just on the teeth, trying to keep it off the mucosa, I feel like can be a good thing. So we use it conscientiously, but I try not to get it in the gums or on the mucosa. If someone has brittle diabetes and their blood sugar is really low and they might die, they put the glucose gel under the tongue sublingual. If they drink the juice, they might die. But sublingual is the fastest route to get it systemic. If someone has chest pain and they're a cardiac patient, they take their nitroglycerin, it goes sublingual. Sublingual is the fastest, most effective way to get things systemic. So if we don't want fluoride systemic, we try not to get it sublingual. So there's ways to do fluoride treatments just conscientiously on the teeth, not getting it sublingual on the mucosa to minimize the systemic absorption. What I have found to be very effective is iodine. So we'll do iodine treatments. We have iodine gel or iodine treatments that are good for our bodies. Most people need more iodine. But I've also found it to be really, really effective reversing cavities on teeth. So sometimes kids or adults who are cavity prone will make these Essex trays or this little soft material that they use a gel and put this iodine gel over the teeth. And we could give you, if you want to look into this kind of stuff, we can give you all the websites and information. But I've had people reverse cavities with it where it's soft, but then it gets hard and scratchy. And we've had really good results with that for people who are consistent and diligent. Most people, it's kind of like a New Year's resolution. They start out good, but then don't follow it, and then the cavity gets worse. So I'm very careful, like I'm very upfront. You've got to do the program for this to work. If you do this casually, it will not reverse your cavities. But on the kids or teenagers, it'll make it'll make their teeth more cavity resistant in the future. So those are some aspects like of my thinking or philosophy. But certainly like I totally agree. Like we can all see 10 people and
Yeah.
have a different idea and recommendations. So I'm very careful with how I word things or what I say. I always want to support my colleagues and really see the best. I know we all have good intentions. We all want to help the best we can.
Mhm.
So, in one way being conservative might be drilling on the tooth, and another way being conservative might be not drilling on the tooth. You could look
Yeah,
at conservative treatment in both ways.
correct.
That's so very,
Yes,
yeah.
absolutely. I agree
So it's
100%.
it's really like getting with the colleague, coming to a common understanding, and working together.
Mm-hmm.
Yeah.
No, very, very
That was very nice.
nice
Thank you,
too.
Nate.
Yep, wonderful. Yeah, so doctor, do you teach any courses on airway and airway geared orthodontics?
Yeah, so I teach a quarterly course up at OHSU, the dental school in Portland, and we've had people come there and bring their assistants there. And then I also travel to offices and do courses at offices. So that's also through the Oregon Health and Science Dental School Continuing Education, but we just have a course for your office and we do it there.
I see. How do I gather more information on that? And does it teach the appliance, the Tanner Airway appliance?
Yeah, that's right. Yeah.
Okay.
So, and I can teach about lots of things, whatever you want to learn about, whatever you want to help your patients with, anything I've had experience with, I can help teach and train with.
That's wonderful. I just wanted to see like your like growing kids. So do you do expansion? So this is airway cleared, right? So we are also treating the narrow arches with this. But if there are patients with crossbite, like posterior crossbite, and other issues where we really do need the transverse opened up, um, are you ever using rapid palatal expander at all, or you just use this instead?
No, we use rapid palatal expanders too. Yeah.
I see. I see.
Hmm.
So, are you able to tell me a little bit more about Tanner Airway Appliance and how does it work?
Can we see a picture, Nate?
Yeah, absolutely. Um,
And then I know that you have not seen Chloe in the office yet, but I do have her scan.
okay.
I'm happy to show it to you just to show you what her case looks like.
Oh, sure. Yeah, absolutely. So, okay, let's show this. So, um, oh, okay, and so do you know the history of sleep apnea, Dr. Rana?
No,
Let me.
no, I don't know the history.
Can you see my screen right now?
Yes.
Yes. Uh-huh.
Okay, let's just do that. So this is Dr. Christian Gimeno. He's a cardiologist. In the 1970s, he was at Stanford.
Mm-hmm.
And he saw these complications, people dying, people having complications after his heart surgeries. And at that time, there was no real monitoring equipment. So in the 1970s, he would have his nurses stay awake around the clock all night long with a clipboard and a piece of paper and just take notes and write down what was happening at night. Why were some people dying after heart surgery?
Mm.
And he found that the nurses were reporting, he's looking at these written reports of little summary of what was going on at night. And the ones who were dying and not having a good recovery after surgery were having these breathing disruptions. And the nurses were describing these breathing disruptions, the snoring or the stopping breathing. And the ones who had that had more complications or fatalities following heart surgery. The ones where they did not get that report didn't have those surgeries. So he's the first one that discovered sleep apnea. He defined the term obstructive sleep apnea, and he defined the term upper airway resistance syndrome. You're probably familiar.
Mm-hmm.
He's the one that created the apnea hypopnea index, which you're familiar with.
Mm-hmm.
Kat?
No, but keep going.
So
I'm following.
what the apnea hypopnea index is, when people say, oh, I stopped breathing 10 times an hour.
Okay.
That's what this is. The apnea is a full cessation of airflow. The hypopnea is a 30% or greater, a partial cessation of airflow. So heavy snoring where there's reduced airflow is a hypopnea.
Mm.
The upper airway resistance syndrome. So to have sleep apnea, you have to have a full no breath or a partial breath that lasts 10 seconds or more. Upper airway resistance syndrome, and those have to be 5 times an hour, almost every 10 minutes. So every 12 minutes all night long, 5 times an hour, every 12 minutes, stop breath or partial breath that lasts 10 seconds or longer.
Mm.
For upper airway resistance syndrome, it's less than 10 seconds. So you could have an apnea or a hypopnea that lasts 8 seconds, 20 times an hour, every 5 minutes, or every 5 minutes, 20 times an hour, but it only lasts 8 seconds. That's considered within normal limits, no sleep apnea. But is that quality sleep?
No.
That's called upper airway resistance syndrome. When it lasts 10 seconds or longer, then that's sleep apnea. So when we're younger, we arouse and we wake up and we breathe. Our fight or flight goes off and we toss and turn and we breathe. When we get older, we get adrenal fatigue, adrenal failure, and we don't have a natural response to breathe as soon. And so then it's lasting more than 10 seconds. Then we need the CPAP machine. Does that make sense?
Yes.
So in the 1970s, he was doing a tracheotomy to help patients. So a hole in the throat, this was the gold standard of care in the 1970s. They would open this plug and breathe through their throat at night, then put the plug in there so that they could talk and have air passing the vocal cords and breathe regular during the day. And they would live the rest of their life with one of these in their throat. They could never take a shower. They could never go in a swimming pool because of risk of infection the whole rest of their life. So he said there has to be a better way. So he came up with the CPAP machine in the 1980s. So for 10 years, it was this.
Wow.
The 1980s, in the 1982, he did trials on dogs. After that started getting some success, he started treating adults, and it was a condition of the elderly. But by the 90s, 2000s, more and more middle-aged people were having sleep issues and sleep problems. And then today, there's children on the CPAP machine. because they're desperate to help any way they can. And what does a CPAP machine do for a child as far as their forward growth? More forward growth or less forward growth?
Less forward growth.
It's putting
Absolutely.
a backward force on their face, right? So Dr. Gimeno said there has to be a better way. If we can make room for the tongue and the mouth, we may be able to eliminate the development of obstructive sleep apnea. So he spent his whole years in Stanford until 2000, until he passed away. This is an airway crisis of what's going on today. And we have so much opportunity to help people. So many people are on a health journey. In fact, I just saw a lady today who's like sleeping in some kind of electrical filled tent, wearing a hat with some kind of protector on it because she's so sensitive to electromagnetic fields. And she has a small mouth. And once you know it, I look in her mouth and she's a premolar extraction case. And it's like so many people are more susceptible because when you're not getting good sleep your whole life, your immune system is so dysregulated and so many issues and piece to the puzzle. So this is Stanford, where Dr. Gimeno spent his whole career helping to advance this, but they're at the forefront, and this is a baby. Tell me if you can hear this.
But we can see.
But I can see the whole chest is.
Look at the mandible.
Like, look here, the
Yes,
gasping. Yeah, there is hardly any.
Struggling to breathe,
Mm-hmm.
right? So this is Dr. Stanley Liu, who worked with Dr. Christian Gimeno, and he was asked a question about lateral expansion with opening the airway. And this is what he says.
I will say that, people always say, well, if you expand the maxilla and then so the airway expands, and so when you see the expansion, say even during DICE, that's what it is. And I'm going to say that's not possible because first of all, for you to physically dilate the pharyngeal muscle wall, okay, you need an advancement, and that's just anatomy, and then we can.
So he's talking about lateral because all the dentists are focusing on lateral expansion these days, but he's saying you need the advancement. If you want to fully optimize the airway, you have to get, and that's what Christian Gimeno was saying is developing the jaws forward. So anyway, there's a lot of research. These are all the research articles on all this, about the arches. So this is in Stanford right now. What they're doing is developing the jaws forward non-surgically now. So here's a video. Okay, it's that. Here, this is the same baby that I showed in the beginning.
Yeah. Very nice.
So they're using these orthodontic plates. This is taped to a little appliance that's helping to promote forward jaw growth.
So how is this attached in the mouth?
It goes up on the palate. And it's got these see this right here?
Yeah.
So it goes up on the palate, and I think they tape this on or attach this, but it helps get the jaws growing forward.
Wow.
So this is forward jaw growth on these little kids. But it's like, because what's common, Rana, so tell me if I'm wrong here, but it's so common, more and more people are doing the reverse pull headgear, right?
Right.
With the anterior crossbite. Are you recommending it to every patient, even without an anterior crossbite?
No, it's only for anterior crossbite. So we are not guiding forward growth in every patient.
But what are the chances that more patients would benefit from more forward growth?
I agree. More patients will benefit.
In orthodontics, it's just common we focus on the teeth and the relation of the teeth.
Mm-hmm.
And I have a way to get both jaws forward. Sometimes the upper jaw is too far forward, and
Yes.
people recommended take out premolars, bring it back to the match the lower. And I'm like, no, let's
Mm-mm.
bring the lower forward.
Forward, yes.
Sometimes they're in a class 3 and the lower's out there, and they're recommended surgically move the lower back. And I'm like, no, let's get the upper out
Upward
there.
forward. Yep.
And if both jaws are back, let's get both jaws forward as much as we can, right?
Mhm. Yes, absolutely.
Does that make sense? So I don't
Oh, yes.
know. But so this is like one of my child
This,
cases. So she
this is
came
so
in
beautiful.
not sleeping well. She's a 2-year-old and sleeping so much better. You can see the energy in her face.
Uh-huh.
But we do these little appliances that they can be removable or they can be cemented in. So either way, whatever you want. But it helps to get that lower jaw. This is like an 8 mm overjet,
Mm-hmm.
but this is like a 4 mm overjet.
Mm-hmm.
So we're guiding the forward advancement of that mandible. She went in for a follow-up sleep study and had a PSG done, and she was told she was negative for obstructive sleep apnea.
I see. Nice.
So this is her mom.
That time was fun. It's amazing. Like instantaneous. She started eating a lot more and putting on weight. It's been a total noticeable difference. Even my mom, who FaceTimes her from another country, notices that when she's playing, she's focused, and she's not so she's irritable. Everyone has noticed the difference. So
So, because some people are a little shy to treat 2-year-olds, but it's like when you hear stories like that, this little girl, she was stopping breathing at night as well. She wasn't breathing well. You could see how small that mouth is.
Right.
This is 16 primary teeth. Her baby second molars aren't even in yet.
Mm-hmm.
If she closes all the way down, she kind of goes into a deep bite.
Mm-hmm.
She doesn't want to close down. You can see her tongue hanging in there.
Mm-hmm.
You see the mouth breathing here. But we develop her out and lots of space, sleeping so much better, her bite way better. So here she is coming down. That's with her little appliance in.
Yeah.
And I think I have her before and after. So just really not sleeping at all here, sleeping so good over here.
So with the appliance, doctor, how does it widen the maxilla? Like, does it do you have to do anything to the for a rapid palatal expander, we crank up the screws, right, to get to the so how does this work?
So this screw angle is custom set for the horizontal and the vertical.
Uh,
So if this is a really, really wide mouth, we'll have both of these screws be parallel and we'll only do the forward.
okay.
But if they're a little narrow also, we'll have these kind of offset to get the width, either slight width or increase width as we get the forward. So this is maybe 65% forward, 35% width.
But I see. Got you. And that we decide on once we take the scan and see like how the narrowness of the maxilla is, and based on that, you decide which way you want to guide the expansion
Yeah,
or
that's right.
growth. Okay.
Yeah, yeah.
So then if you want, let's say you finish what the appliance is set up for, whatever expansion you're doing, if you decide you need more, you need to fabricate another one, or can you somehow modify that?
Each appliance is generally good for 6 to 8 months.
Okay.
Sometimes you can modify it to get some more life out of it. Sometimes you might need a second or a third one.
Mhm.
And this is cemented on the teeth?
It's both. He said it can, you can have it removable. It kind of snugs, like locks on the teeth, right? Like a night guard or something.
Yes.
Okay. Or you can even cement it like what we did for
Indeed.
Indy. Yes.
So then, Nate, like this needs to be worn. If it's not cemented permanently, it still needs to be worn as close to 24 hours. Is that correct?
Take it out to
For it
eat.
to work? Yeah. Okay.
Yeah, take it out to eat. I get a minority. There's a few patients who only wear it at night,
Okay.
which is okay, but then it's gonna take a lot longer.
Mhm.
But for some people, that works for them. But I want to coach people to do the best they can, but everyone has things they have to manage in life, and for some people, nighttime can get the results.
So how do you expand an adult palate?
That is all surgical. He was talking about MARPI and stuff, which is like more of like a surgical expansion, where you put implants in the palate and then you put the expander there.
Okay.
But yeah, that's one thing I've done with adults, but most adults do non-surgical. Yeah,
You still do non-surgical on them too?
yeah, yeah.
Okay.
Yeah, I'll
Yeah,
show
I
some.
would like to see that.
Here's another 2-year-old. You see the tongue sticking between those teeth?
Mm.
I say close down. She closes like this because she can breathe when she closes down. I put her jaw back like her bite really is, and she kind of gets claustrophobic and feels like I'm trying to suffocate her.
Mm.
But she's stopping breathing, waking up, crying at night. And here's the mouth. The baby second molars are not yet in, and we use our appliance to grow it out like this.
Mm.
And here she is, lower jaw rolling back more to more forward there. What do you think?
Yeah. Okay, good. So how long did she wear this appliance? Was it all just one appliance wear, or did you have to make multiple?
We did one appliance in this state, and then I think when her second molars came in, we did another one.
Another one, I see. And
Yeah.
then one thing I wanted to just clarify, so those screws, I know like, so does the patient make the changes into the screw? You teach
Yes.
them how to, so they remove the appliance, crank it, and then put it in? Like, how does
Yeah.
that?
Yeah.
Okay.
Yeah. Although the pedo ortho dentist that I was telling you about, like he likes to have him do it removable for like 3 or 4 weeks, so it opens up a little bit. Then he likes
Mhm.
to cement it in and just have him turn it in the mouth. He says he gets faster results
Right.
keeping it cemented in.
True.
And
Yeah,
right at
because,
the beginning, go ahead.
oh no, I'm sorry. Go ahead. I wanted you to
Yeah,
finish it.
so he's like, you should tell everybody just cement it in. It's so much better. So I'm like, okay, I'll start telling people.
Yeah, I was wondering about the compliance. So if we keep it removable on a 2 or 3 year old, like how do you manage the wear time and everything, like how do they comply?
Yeah, they do really well with it. Yeah, they do well. Yeah,
Okay.
if they don't, If they don't wear it really well, then we cement it in and then they get used to it. And then we take it out and then they're good with it.
I see. Do you deal with some open bite when you remove them because of the padding that's there? Posterior
Um,
open bite.
usually not. I have not had that, really. But if it does, like that'll close up in
Mhm.
the primary or mixed dentition.
And do you do anything to retain it or like, let's say you keep it in active expansion, so you are cranking up with the screw, right? And
Mhm.
you got your expansion that you needed. Um, then what would be the protocol? Do you keep it in for some time for the suture to kind of become steady before you remove it?
Yeah, or we'll do an Essex to wear at night to stabilize.
I see. I see. Okay.
Yeah. So let's see, here's another one. No space between the baby teeth. What are the chances this kid's gonna have crowding?
A lot, big time.
Does he need a face mask?
No. Yeah, I see that.
So here we are. So we developed him forward about 8 millimeters.
Hmm.
We also increased his width quite a bit. Here's his smile.
Mhm. Interesting.
Now he could have closed down. This is where he was posturing forward.
Yeah, yes, yes, yes.
But my assistant didn't want to force his jaw back and suffocate him like I would have done taking the photos. So this
They
was,
are too nice to the patients.
he was not, yeah, he was not end to end. He was not class 3, but
Yeah,
he postured forward because that's where he breathed.
I see. That's insane. I love it. This is great.
But my experience is I'm not going to get this lower jaw forward like this. See the high nose lip angle a little flatter here?
Mm-hmm. Yes,
So just doing the lateral expansion doesn't get this full development.
I agree. Makes sense.
What do you think?
Yeah, forward growth is amazing. I never thought of the forward growth. Um, that really is a game changer here.
Yeah, yeah. This is one of my patients who won the gold medal in the Olympics.
Oh, wow. That's
And
so
this was his
great.
airway, front to back, 22
Mm,
millimeters.
mm.
So did his ability to breathe oxygen help him? So this is an article from the 1970s, 1973. It's ironic we've limited ourselves in maxillary orthopedics to the lateral component and have ignored the anterior posterior discrepancies. Trying to bring attention, we need to get the jaws forward, on a class 3, but
I see.
okay, you're asking about adults, so here's an adult. Constricted, jaws trapped in. Where is she? Okay, here's her. Like, where's she at? Okay. So constricted, a little bit of crowding on the bottom, wear facets, grinding the jaw forward because the body wants the jaws to be forward. Bags under the eyes, jaw tension, really, constricted arches there. And where is she? Okay. So we advance her. So see all this space right here behind the
Oh.
canines?
Mm-hmm.
So we advance her about 8 millimeters forward. And see, the lower jaw came forward with it. She doesn't have a big overjet. This is her bite. And once the lower jaw remodels, so is the lower jaw expanding, yes or no?
It looks like it is a little bit.
So it changes shape.
Mm-hmm.
So because the suture is fused, she has bigger width. Can we non-surgically expand the palate?
With adults, I think no.
So and there's research articles saying maybe we're getting, alveolar remodeling.
Tipping, yes.
Maybe some tipping. But there's maybe a little bit of tipping, but not a lot.
Mm-hmm.
But there could be what some studies show is that there's some remodeling even at the suture.
I see.
And then the lower, some people say, oh, the mandible cannot expand, but you're doing expansion, so you're getting some change in shape of the mandible already.
Yes, I'm doing that with aligners all day long. It's beautifully getting shaped. I can show you some cases afterwards too, but I'm just so intrigued here with the forward growth. That is really
Yeah. Because
an
once this
eye-opener.
mandible comes forward, it does not want to go back. I
Yes,
mean, both of you could move your lower jaw back as far as you can, more comfortable or less comfortable.
less comfortable.
Right, Kat?
Wait, I'm thinking like when you're changing the jaw, especially the lower jaw, if it's posturing forward, what happens to the TMJ and the disc?
Mm-hmm.
Most people have too much compression on the TMJ disc. So what happens is the clicking and popping goes away.
It goes away.
It goes away most of the time, not 100%, but most of the time.
Okay.
And then the other thing is that there's remodeling and change in shape of the whole jaw bone. So here's her after.
So after you created all that space, how did you bring all this posterior teeth forward?
We used to do braces. More and more we're doing aligners.
Right. Okay.
But what I did, here's her before and after. But we bring the premolars forward to where we want them. And then we do bonding on these interproximal composites. We brought the molars forward, and then once we got them close enough, we did bonding on the mesial to close up the rest of the space.
I see.
So sometimes we'll do some interproximal composites. Here's the lower.
That is just to close some spaces, like residual spaces, interproximal spaces.
Yes.
I see. I see. And how long did she wear that same Tanner Airway appliance?
Yes.
I see.
About 8 months or so.
8 months. Okay.
And then they'd go into the aligners.
I see.
So I think this would be a great first step for people who are interested in, getting more of some of what this can offer, then doing the aligners as the second step.
Correct.
But you can see almost the angle of the jaw is a little steeper here, higher mandibular plane angle here, a little smaller here.
So this could be a good treatment remedy for the deep bite cases, right? All
Yes.
day long,
Yes.
because those are the hardest one to treat in general.
Not
But with
anymore.
with this, I'm just saying, like, because most of it is like the mandible is trapped behind the upper incisors. They are all retroclined. You can only like advance them so much, otherwise we'll be blowing them out of the bone. So you're always like fearing that. But if with this appliance, if I can protract the maxilla forward, the
And
problem solved.
upward. And
Upward.
upward.
Right. And that's just problem solved right there. And then you just bring the teeth in position.
Yes.
Um, because right now with aligners, I'm mainly focusing on the curve of spee, like leveling the curve of spee, and I look at their smile line and making sure that I'm not intruding the upper incisors as much because I don't want them to, look older than they need to. Because as they get older, their lips are going to drop and everything. So when I'm treating a deep bite case, I'm focusing on where their gum line is and where their lip like how much is the gingival display when they are smiling, and
Mm-hmm.
then based on that I decide how much I want to do. But all we do is just the way I do it is just procline the teeth forward first if they are retroclined. Once they are out of the way, mostly lowers are also lingually inclined, right? So they are mostly like this. So procline first, procline this, intrude, and then we retract this back. But there is no need to retract this back if we can bring this forward.
Yeah, right. That's right. Because you want the whole mandible to come forward to get the back of the tongue forward off the back of the throat.
Makes sense. Makes sense. So this is wow.
Okay, so
My
what do you
folks.
charge for that appliance, Nate?
I'm not done showing you my cases yet.
Well, show me the cases, but like, what do you charge your patient?
300. 300.
And that's gonna okay. So is that gonna
300 for
that's
the whole appliance
nothing.
and all the
Wait.
8 months of monitoring and everything?
No. Okay. No, that's the lab fee.
That's the lab fee.
Got
Hey,
you, got you.
I was gonna
Okay.
be up here.
300 is the lab fee, which
Yes.
is
Yeah.
great. How much so this is considered um like keeping this stupid insurance thing. Sorry, I'm like whenever insurance is in there I just can't speak straight, but whenever keeping insurance in mind, like this kind of appliances, like what kind of like coding does it go under, or do you just I think it's make it as a part of your ortho coding, like the comprehensive ortho, or do you create a separate code, or do you do like how do you deal with that?
Part of ortho coding.
It is part of the ortho coding.
That's what we do. Yeah.
I see.
Yeah.
So there is not a separate code for this appliance.
I mean, you could make a custom code for it,
I
you know,
see.
if you want to do something. Are you in network or out of network with insurance?
We are in network right now.
Okay. How many days a week are you?
Do I work? How
Yeah,
many days? I work about 4 days a week.
4 days. Okay, because you guys. So so your ortho's in network then too, or what?
So ortho is about 2 to 2.5 days.
Oh, well, ortho's a separate thing. So ortho, they cover so much. Ortho, they pay 1,000 or 2,000 or whatever their benefit's going to be, right?
Correct.
So yeah, if you want to, so some people bill that, some people do it as a separate thing, and
Got
then bill that when they do the aligners.
I see. I
So
see.
whatever makes sense is fine.
I see.
Nate, can I ask you a couple questions?
Yes.
So when let's say if you're gonna be combining the appliance with aligners, how often do you need to see the patient to be checking on the appliance and the progress?
Mhm.
Actually physically see them.
Yeah, I see them every 3 months.
So then if it's about 8, 9 months treatment, you see them like 3 times and you're done.
Yeah.
Okay. And then
Go ahead.
then once you're done with the appliance and you are ready to transition to aligners, do you start right away with the aligners or is there a wait
Yeah,
period?
we start right away. Yeah.
Right.
And would that shorten your aligner treatment or it's just gonna stay the same?
Case by case. So I'm going to show you some cases where it shortened the aligner treatment, But the case I just showed you where we advanced our 8 millimeters and now we're protracting all those posterior teeth,
Mhm.
that lengthens the aligner.
That's what I was thinking. I'm like,
Okay.
that case could be more. And now you have to fight the anchorage too, right? Because now you are having you got all your expansion forward, but now as you are bringing these molars forward, how are you keeping this here? Because you are getting same equal amount of force in the anterior too, right? So you have to kind of juggle that.
Yeah, it's sequential. It's just little
I
by
see.
little.
That's what I was
Everything's
thinking.
got to be stabilized, and we're just moving,
One
a
tooth at
little
a
bit at a
time.
time. Yeah,
Got you. So it takes time.
yeah, yeah.
Do you think you could do a little bit less on this case and then not have to worry about doing those interproximal fillings and stuff?
Yeah, yeah. Let me show you some other cases. Do you have other questions right now, Kat?
Oh, they will come up, trust me.
Okay, look.
Both
Okay,
of them.
stop me anytime because I get
Please
excited.
do.
But
I see.
One question I have is how do you decide on how much space are you going to create? Like, do you have any like a formula or a calculation that you use to like so for example in this case you created 8 millimeter of space and brought the posterior teeth forward with sequential mesialization. Um, that 8 millimeter like of calculation, do you have like some sort of a formula to decide that? Like how do you like
Come up with.
come up with that I'm going to protract the maxilla this much forward?
so, so we want to get. I mean, ideally, we want to get a point over. So
Mhm.
some of the things are looking at the nose lip angle,
Yes.
90 degrees or less,
Mm-hmm.
or close to 90 degrees. Another thing is looking at the Bolton profile. Have you seen the Bolton?
Yes.
So looking at the Bolton, where the jaws are in relation to the Bolton.
So if there is a mandibular excess of certain millimeter, you know that we are that much deficient in maxilla. Is that
Yeah,
correct? And then that becomes like your one of the guiding measure that, oh, like, you know how if it will say there is like a, how do I say it? Usually, let's say it's 4 millimeter mandibular excess in the Bolton. That means that our maxilla is 4 millimeter constricted, correct?
right, right,
So that's how much I want to create the room. Is
right.
that how you make the decision?
So I just work with each patient on what they want.
Mhm.
If they're like, there's a history of sleep apnea in my family, I'm not sleeping good, I want to get the very best benefit, I want to go to the extreme, then I'll work with them. Most people, they go for 3, 4, 6 months and they're good and they transition. But some people, this is great, this is awesome, but I want to do more. And so it's really, I listen to the patient because they'll get fatigued out on using these appliances
Mhm.
and I want to keep them happy. I don't want them in the appliance longer than they want to stay with it. So I
Mhm.
try to feel their energy. I recommend what I feel like would be a good benefit for them. But when they're fatigued and tired out with it, I say, let's transition you. Let's do the aligners. Let's get you finishing up.
Sure, gotcha. I see. So when you do the self analysis, you are looking at mainly the A point, where the A point is in relation to the B point, correct?
Yeah, so there's some research articles that show these points. And in fact, we'll do, like, I teach a study club once a month. So
Uh-huh.
we should circle you in. And I'm going to teach about, the cephalometrics and what we're looking at on
Mm-hmm.
that
I see.
and what the points are relating to this.
That would be, yeah, that's what I mean. So I'm a mathematic learner, so I'm like, my brain is going there, like, so, like, what would be my diagnosis criteria? Like, when so for example, when I was using rapid palatal expander, I'm doing the calculation from palatal cusp to palatal cusp and then the buccal cusps on the bottom. And then I'm trying to see, okay, how much deficient is my maxilla? and how much correction and possible overcorrection I want to get. And based on that, I say, okay, I want 9 millimeter of expansion in the maxilla. And then I tell the patients to um, crank the screw accordingly to get that much of expansion. But so there is a formula that I follow, so I know how much expansion I'm going to get. So that's what I'm trying to kind of learn. Like, let's say if we are working on creating a forward growth along with it, like what kind of parameters and formula to use to make sure that you're giving them the appropriate expansion.
Yeah, yeah, absolutely. So, and I would say like sometimes on these kids, let's see. Oh, wait.
I'm just going to stand up and stretch a little bit.
Yeah. So, like on someone like this,
Uh-huh.
centrals are normally about 9 millimeters, laterals about 7.
Mm-hmm.
So 16 here, 16 here, 30. We need 32 millimeters, mesial to canine to mesial to canine, to have room for the front 4 incisors.
Yes. Okay.
And then these are the primary molars. But then we need premolars are usually about 8 millimeters, and then canines 9. So we
Mm-hmm.
want at least 25 millimeters here.
Mm-hmm.
So
Mm-hmm.
I'll tell parents first phase, if you just want the front 4 in, then we need 32 millimeters around this arch, and we want to increase this arch until we've got 32 millimeters for the front 4 incisors. And increasing the appliance is designed to go up, forward, and lateral, increasing the width all at the same time. And then after we get that, if they're going good, if they say, okay, do we want to stop there? And then when they're 10, 11, 12, then we'll make more room for the canines. Or do we want to get that in advance? So parents who are very dedicated and disciplined may say, no, let's get it right now. They're doing good. They're doing the appliance. We're making it happen. So then we'll get extra space at age 5. Now he's got room for all of his permanent premolars and canines to come in later.
Nice. Love it.
So this is kind of 32 millimeters here. And then I like to get, we need at least 25, but I like to get 26 or 27. I'd rather have a little extra space than not quite enough space.
Mm-hmm.
Does that make sense?
Yes, it does. And while they are doing this on the upper, mandible is just where it is. It's just naturally posturing forward.
Yes.
Okay.
Yeah, so the mandible naturally, so, and the smooth occlusal surface of the acrylic appliance helps to guide the mandible forward.
I see. So you do put a little bit of a slope or something. I see. Got you.
Yeah, something like, yeah.
So,
In the appliance, he places a little bit of a like a slope or something that guides the mandible to come forward.
Yeah. So let's see. So here's another adult, because we were talking about adults. Can you see this one okay right here?
Yes, yes. She already has some restoratives there.
There we go. Is that okay?
Yes, Doc. Thank you.
But so she has a super deep bite. She came in because she wanted new veneers.
Who put the first one?
I know.
So this is you're getting.
Yeah, she had the gum recession and she was concerned about her smile, right? Her lower incisors are wearing down against the lingua of these front teeth. I mean, you could almost see the pulp chamber showing in some of these,
Mm-hmm.
right?
Mm-hmm.
So it's like, wow. And I think this photo was after she started her expansion. She was even trapped in a little more. You could see the spacing here opening
Right.
up. So, but you can see the wear pattern grinding the jaw forward. And I said, we need to unrestrict you. She's like, no, 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 I just need new veneers. And I'm like, no, 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 we needed. It took me an hour to convince her. Finally, I convinced her, and we did this. We advanced her out about 6 millimeters. She loved it. She had freedom of movement. We used this little appliance to widen out her lower jaw. And then she's able to get her veneers. But she loved her smile and her lip support. So she's really happy with how this kind of came out for her. But she's a big fan. You could see she has her California lips, but it gave her a little more lip support.
Hey,
Jaws forward. What's that?
did you say California lift?
Yeah.
So what happened to the space distal to the canines? And what happened to the whole mouth apart from her veneers?
So
Talk to me more about this.
so she's going down to Hollywood to do her full mouth makeover.
Okay.
So
So
she's going to she's gonna have it disguised, camouflage. The premolar crown is gonna take half of it. The
I see.
canine is gonna be contoured to kind of disguise it. So she's getting full porcelain, top and bottom, everything. But she loves her jaw position now.
I'm sure she's so trapped, I can see. The
Yeah.
mandible is just so like tucked back there.
Yeah, it really, really was. Yeah. So here's another lady, premolar extraction case. And you can see her wear pattern, but she came in, this is her bite.
Oh wow.
So for 10 years, she had an end-to-end bite. She could not get her back teeth together. She was offered braces. She didn't want to do braces. She was offered crowns on all of her back teeth. She didn't want to do crowns. So she just dealt with it till she heard about me. She came in, we got her up and forward. We got her back teeth touching. She's biting and chewing on her back teeth. She's like, I can chew on my back teeth. You are my hero. But if you look close, you can see I did some bonding. I did a little composite on the mesial of the premolar, distal of the canine, mesial of the premolar, distal of the canine. We opened her about 4 millimeters. I said, we could do some Invisalign and close this up in the front. She's like, no, I love it. I can chew on my back teeth. That's all I wanted.
Wouldn't she possibly like develop like a thrusting habit or something then at this point with the open bite in the anterior?
Yeah, she may have. Because this will probably close up on its own. But if she developed a tongue thrust, I'll have to get her in and check for that. If she has a tongue thrust, that'll keep it. But if she doesn't, this will probably just close up on its own.
Its own. Okay.
Yeah. So
So
yeah, I need to bring her in.
this is
Go ahead.
just purely appliance, nothing else.
This is the appliance for 4 months. That's it.
Got you. Now I see what the patient in the morning was talking about. I think that's all she wants is the appliance.
Yeah, yeah, and then some bonding.
Correct. So
But I always tell them most people decide they want to do the Invisalign after. Not everybody, 95%. But there's a few people here and there. I have some TMJ patients. That's all they wanted to get them out of the TMJ. They're good. They don't want anything else.
do you
And they
give
just
them a
let the
choice,
bite settle
doctor, or do
together.
you just do it as a treatment like this is the appliance and then you will go in aligners and we will align your teeth better, because I kind of, yeah, I see like a beautiful protraction and like you helped her with the joint and of course with the airway, but then because the teeth are not biting properly still, could that create more trauma down the road? So, like, do you give them like to follow with the orthodontic correction with aligners after as a choice, or it is like a part of the treatment?
I always recommend it as part of the treatment, but it's their choice if they want to do it when we get to that point.
Mm,
Because some may say no, but then, sometime later they may come back and say, yeah, actually, okay, let's do it.
yeah. So just for the appliance in this kind of cases, what would be your fee for the patient?
Anywhere from 2,000 to 5,000.
Mhm. Okay, and that is just appliance, and then the aligner
And then I
treatment.
charge 300 for the follow-ups.
Oh,
Which,
what follow-ups? How
So I see
often?
them every 3 months
Okay.
to do adjustments on the appliance. And so it's 300 for those.
Oh, so
what kind of adjustments would they need?
Adjusting the class or adjusting the bite or doing a reline.
I see.
okay.
I see.
Okay.
Yeah.
Got you.
So there is a
So
point fee to start, and then every time they come in, there is.
Mm-hmm. Yeah. Yeah, those is all, that's all free here. There are no
so here's a patient who came in with the canines completely blocked out. Would you do aligners with this?
It will be tough creating that much amount of room. I can see your appliance working here right now. I will put Tanner's appliance here for sure. Oh
So
my gosh, this is crazy.
yeah, so it's the narrow V shape that you were talking about, right?
Yes, this is amazing, Dr.
So we
Tanner.
start opening that up.
Mm-hmm.
We get one canine in, the other one's ready to come in.
But wait, wasn't there something to drop the canine down, or we're just
So
gonna?
there's the
It
full
came
part.
natural.
How long, Nate, from start to finish?
2 years. 1 year with the appliance, and then like 1 year, like maybe it was a year and a half or something, in the aligners or the braces or whatever that was.
Okay. The
So
canine
here's
goes
her airway.
the space.
Yes. So Dr. K is wondering if the canines just erupted on its own, or did you have to drag it down?
I have never had to drag down a canine.
Wow. Even what if it's an adult? Would you? How old was this person? It was a kid.
She was a teenager,
Right.
I will
So,
or something.
so then, Nate, if that's a adult, if it's
Yeah.
50-year-old with those canines still there, would they still, they're not gonna drop.
Yeah, unlikely. So they may need some help.
Mhm.
Yeah.
That at that age, sometimes there is even ankylosis there, right? So even with putting things in there, it is very unpredictable, right? To drag the
Yeah, it's
cat down.
unpredictable. Yeah. You've got to tell them up front. It may
Mm-hmm.
be ankylosed. Yeah. Um,
So what do you do then?
but like I really I don't know.
Those are tough ones.
I don't know. So but here's her profile. What do you think there?
Yeah, it's definitely retruded mandible.
And there's her smile.
And yeah, nasolabial angle is very, it's more than 90. I see that.
Look at the buccal corridors.
Mm-hmm.
That's all I'm looking at.
Kind of flatter here.
Yes, that's another, yep, the whole zygoma.
Yeah.
So do you want to flat.
So here's one. You see how crowded? Okay, here's your deep bite. Dr.
Mm.
Rana, right?
Yes, deep bite, 70% of population.
Okay.
And severe crowding. I mean, in Oregon, this is highly likely to be a premolar extraction case.
Mm-hmm.
What do you think of our first phase here?
Wow.
Lots of room on the bottom.
How did the room get created on the bottom, Doc?
Schwartz.
Swords, okay.
Yeah.
Mhm.
Okay, how's this
Fair
to do
enough.
aligners? Easy or hard?
I mean, I've done it and it works. I've done a lot of cases like this with aligners, Invisalign first, and you just procline them forward, you know.
Mm-hmm.
Uh, and it does work really well. And then it creates a big overjet, of course, and then you're guiding the mandible forward.
Yeah, yeah. But even with the bottom, see that lateral
Mhm.
overlapping the canine?
Yeah, it does create quite a bit of an expansion with Invisalign first at this age. So just like you know how you're guiding your with your appliance with the cranking of the screw, you are guiding the teeth buccally.
Yeah,
Um,
yeah.
that's exactly the same thing I'm doing with aligners.
So you get it looking like this after.
Yes. Hmm.
So what
So
happens with this?
lots of space between these teeth, lining those up, but then plenty of room for the canines to come in
Yeah,
later.
I see that.
What happens to it?
So ask him.
Nate, question.
Uh,
I'm looking at this case. So I see, obviously the bone and the gingiva are following you when you do the like anterior segment, right?
yeah.
Forward. So then what happens to the bone and the gingiva in the posterior? Like how do you overcome that step that happens in this phase?
Tell me.
Huh?
Like right here?
Yes.
So, like sometimes I'll grind down and I'll shorten the baby teeth
Okay.
to help close the bite.
But then are you able to correct the bone levels later on with the permanent teeth? Or how is this gonna level up?
Yeah, so we'll level it with the braces or the aligners.
I see. So okay, so you will be intruding teeth then or
Yeah, we could,
yeah.
yes. Yeah,
Okay.
yeah.
Okay.
So here's his profile.
So then that's gonna be like what we just saw, that's gonna be phase one and right?
Uh-huh.
And then are you gonna wait until all permanent teeth come in to do the phase two, or are you gonna be doing when do you start?
Yeah, it depends on the parent. Some parents want to get them the front teeth lined up like right away, and so we'll do just a short Invisalign to get the front teeth lined up a little more, and then let the permanent teeth come in, and then evaluate and take care of what's needed after that.
If the parents were not a factor, when would you do it?
When would I do the
When would you start that phase two?
phase two?
Yeah, to correct the step.
Oh, I mean, younger is better.
Yeah.
I think doing it younger is better. So I think just setting things up at a younger age is
Mhm.
nice. You get more facial balance. When you start to change one cranial bone, all the cranial bones start to change simultaneously.
I
So the
see.
younger we do that, the more the whole mid face will develop in a nice way.
She's very flat here.
Yeah. So say she's collapsed back. She needs a whole premolar in this space right here.
Mm-hmm.
really crowded, backing in. We start getting a little space in there. So that little space that you saw is now this space. Now do we have room for a premolar?
Mhm. This is after removing the appliance. Okay.
Yeah, so here's her appliance. So we're trying to get her whole face forward and opening her airway the best we can.
Mm.
Here, I think she's in her aligners, but you can see there's extra room around those premolars.
Mhm.
So she went from super crowded to some really, really nice arches.
Right. That's beautiful. How many years in the treatment altogether?
So look at this high nose lip angle, flat lip.
Mhm.
So this we developed her out, then we waited for the permanent teeth to come in, then we finished her up. So
I
this is
see.
probably like 5 years between these pictures or something.
Mhm. I see.
But see how the maxilla is just down and back, and we get it more
Yeah.
up and forward.
Mhm.
Higher nose lip angle, smaller nose lip angle,
Right.
jaws inset to forward. So there was no anterior crossbite, but we try to get everyone forward as much as we can because that translates to a better airway.
Definitely.
Yeah. So here's one. She was recommended 4 premolars to be extracted. And I know you could definitely do this case without extractions, right, Dr. Rana?
Mhm. Yes, I can do this without.
So here's her appliance. So we open this up, creating the space. So this is just 8 months after the appliance.
Oh. Mm.
So is this going to be an easier and shorter Invisalign case?
It will be a longer case, of course.
Yeah.
For,
Yeah,
I mean,
longer, but then but
without
after,
this, it will be longer, is what I meant.
yeah, before, right? So it'd be a lot longer
I
here,
can do
but
this.
here it's gonna be a lot easier.
Dr. K can do this
I
one.
can do this one after you finish the hard
Yeah,
work.
yeah, it's more challenging here, right? But it's really easy here. So it's kind of like, this one, I don't have the occlusals side to side, but if you look at this arch and bite to looking at this arch and bite, it's just a whole different mouth.
Yeah, definitely, definitely.
But so no, yeah, like I love it. I could spend another 5 hours.
I know, I can see you're so
I know you
passionate.
guys, you guys have done Tony Robbins, so we could stay up past midnight, right?
Exactly.
Anytime.
We are
Turn
on
on the
Tony time.
music. We should turn on the music and
Yes.
keep the energy up. But like, did you see anything here of value? Do you feel like this is worth like learning more about? Would you like to join our team and offer this to your patients?
Absolutely, absolutely. I want to learn more about this. How can I gather more information on this?
So, what you can do, so we have a training portal and we've got our system, but we want to get you logged onto our training portal. And normally we charge $3,000 for the training program, but for offices who take over cases and help continue provide continuity of care, like we give it complimentary.
Oh,
So
So,
if you would be willing to work, let me guide you on the patients who are down in Sacramento and see them, but then like, set up your own financial agreement with them. But what we kind of normally do is every 3 months they pay 300. And so it's like, but you take the money And then I would like to come down once or twice and help work with you with the patients and help your team, and we could coordinate. But help get you trained on that and help work with the patients as you guys get going. So we'd love to coordinate with you and do some stuff as well.
And what I heard is you normally charge $3,000 for this, but for people or doctors who are wanting to work with you and grow this skill and master this skill, there is no fee. Is that what I heard?
That's what you heard. Yeah. Yeah.
That's so generous of you, doctor.
Yeah. I really believe that this is a good thing, and I want it to be a win-win, and I want to help you be successful. I appreciate the opportunity working with you as well.
This
It's a
is
great service to the patients, and it's challenging. It's easier doing the aligners. I have offices that say, well, we're doing airway, the aligner's easier, that's all we're going to do. But can you see a benefit to doing this before doing the aligners?
I do. So yes, absolutely I do. So when do you see like w- this appliance gives us the transverse and forward growth ability. So now if this appliance is available, when do you choose RPE um, instead?
Okay, let me show you.
Like in what kind of cases would you like pick RPE? Like I'm just trying to like narrow down, like I want to like, like because I can see the advantage here of forward growth all day long. I think this is amazing. But
Yeah,
RPE doesn't give us that.
yeah. Um, so here's our phase one. So I'm pulling up. Um, hmm, okay, let's see. Okay, so this is like a child who came in. He may or may not have had room for his laterals. It's going to be a little close. But the mom was passionate. She wanted to develop him out and open his airway the best she could. So this is the lateral. I wish we would have had a cotton roll in at the beginning,
Hmm.
but sometimes they go from like a 34 intermolar width to like a 44.
Correct.
So just getting a really nice width. But tell me, what was your question, Dr. Rana?
When do you choose to go for rapid palatal expander instead of Tanner's airway appliance?
Okay, yeah, good question. So
You're asking Tanner.
what I just showed you, we did the Tanner Airway Appliance,
Got you.
right? So that was the one I just showed you. Um,
So I guess that's a question of when would you not want forward advancement?
That's exactly
It's
what
like
I'm asking.
that's
Don't you want
so
forward
this
growth?
one, this next one,
I can answer for you. I've mastered this
um,
already.
so this next one is one, I'll tell you what we did here.
Because you can have the Tanner and still, if you only want the horizontal.
Yeah,
It's horizontal code, right? Whatever
right.
it's called. So you can opt to do just that,
That's true.
right?
So you know how rapid palatal expander allows like 9 millimeter, 11 millimeter, 13 millimeter screws, and like you can get that much amount of expansion. With Tanner's appliance, how much of maximum expansion can you get?
8 millimeters.
8 millimeters. Okay, that answered my question. So if I need
Eight.
more than 8, I will need RPE.
Oh, like, oh, the screws that we use open 8 millimeters
Got you. So that's how much expansion you can get to the most, correct?
for one appliance.
Oh, so then you change the appliance and then start
Yeah,
crank
like that case where the girl had two canines completely 100%
blocked
blocked
out.
out.
Uh-huh.
She went through two appliances.
Got you. I see.
So you can do 8 millimeters horizontal
And
and
forward.
forward.
But her
Yeah.
screws were angled, so she got, I think we went like 11 or 12 forward with her, and
Mhm.
we increased the width about 8 or 10.
So you know this when you plan the case and you are automatically planning two appliances in your fee.
Yeah, that's right.
Got
Yeah,
it.
yeah. So here's one where we did a Tanner Airway appliance, and we started getting her forward, opening up room for the front four teeth to come in. And then her lower was kind of set back. She started getting an overjet. And so then we're widening out. The lower is nice and wide now, but it's set back. I want the lower to catch up with the forward, but the upper still needed a little more width. So for her second appliance, we did an RPE.
Hmm.
So we got her upper forward, but it wasn't as wide. And
Got
so
you.
we just wanted to get the width.
Got you. Got you. Okay.
So usually I'll do an airway appliance to get the forward and the width. And then after that, I'll either do a second airway appliance to get more forward and more width, or just an RPE to get more width.
Okay, so one question I have, can you do only transverse with your Tanner's appliance and not do the forward? Let's say you achieved forward growth, which you did already, and now you just need more of the transverse. Could
Yeah,
you program that in the Tanner's appliance and not do the RPE?
yeah, we can. Yep.
Okay.
Hmm.
So what I'm trying to get to is if I learn to utilize Tanner's appliance properly, I may not have to use RPE.
Correct.
Okay.
Yeah,
One
correct.
appliance does both for us.
That's right. That's
Okay.
right. Or you could do the RPE and then do the Tanner Airway appliance to stabilize the RPE as you get the forward advancement.
Got you. You can be very creative with this. Got you.
Yes.
Okay.
But you want to set the expectation that there's going to be a second fee. If there's a lost or broken appliance,
Hmm.
or if you're not wearing it and we don't get the results and you want to do a second one, it's going to be another 500 or 600 for each additional appliance.
Got you. Absolutely. Sure. I know people do get paid for things. Yeah, I do a lot of free dentistry, I feel. And I need to get better at this, creating value.
Don't look at me.
Yeah,
Nate,
yeah. No.
She is a blessing. She is complete counterbalance of me, and I've learned so much from her.
likewise.
Like I never, I mean, I'm still struggling with seeing this as a business, and that's why I'm with Tony Robbins. I need to change that.
Me too. No. Let's
There is
help each
nothing
other, Dr.
wrong. There is nothing wrong with seeing this as a business. But in the past, there is just has been this guilt that, oh, we are healthcare providers. We can't be like looking at making money out of this. That is how I looked at it. But that's not the right mindset. Like after being in this field for so long, now I'm realizing it that money is part of the process, in order to learn and grow and help more people. It is the driver, you need that.
Yeah,
And
yeah.
if I'm not focusing on that, ultimately I'm just not reaching out to many people that I could help.
Right, right. Yeah, absolutely. No, I
So
think you'd be very successful with this. How many operatories do you guys have?
we have five.
And then how many days a week do you both work together on the same day?
3.
So there's 2 days where you're not.
Yes, so
One day.
one day, Wednesday is the day I'm admin. So I'm doing mostly like working on my cases and working with the team and all of that. But Mondays and Tuesdays we are working together. Um,
And Thursday
and
she's
Thursday I am by herself. Dr. K is not here. So Thursday is the day I still do full general dentistry and ortho on that day. So I'm on
And
the floor.
Friday?
Friday we are closed, and Saturday, Sunday.
Friday.
I mean, sorry, I take it back. So Friday, Dr. K does sedation cases on Friday.
Oh, okay,
So
okay, 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 okay.
those days are just blocked for sedation and appointment only. And like that day, she comes in with limited team members, with one EF2 and one DA and her, and they do like long, comprehensive, large cases, and patients are sedated. And it's only one patient at a time.
Yeah, okay. No, that's great. Because yeah, what you have is like you could have one chair that's almost like a hygiene
Mhm.
schedule, and you have a dental assistant working the airway patients, doing the deliveries, adjustments. You're probably already doing that a little bit with your Invisalign, having the assistant
Correct.
handle a lot of that.
Yes.
So they could get trained on this and then incorporate that and, do their 20 or 30-minute recalls, learn the adjustments, learn the relines. We want to help train them in the system.
So, Nate, you said that you do travel to offices for trainings.
Yes, yes.
How often, or is that like because you talked about the portal. I don't know if that's part of the port. I don't know what's on the portal, I guess.
Yeah, there's like learning modules you go through and you learn all the
Okay.
steps and it goes through a lot of how to do the treatment, the diagnosis, the planning, the
Okay.
follow-ups.
And then when you do come to the office, it's not that you're coming every so often. It's as needed, and if
Yeah, we get on a Zoom or we get on the phone, but we're close enough. I'd love to drive down, you know, and
okay.
help you. Like, I have some patients that I started up here, so it'd be nice to try to coordinate if we can, if I can be there and just help things. Um, I'm a personal touch person. Like, I like to be connected. It's like I'd love to meet everybody and go everywhere, but when I can, it's nice to get in the office. But I find when I go there, it just helps. I can help answer questions with your team. I can practice with them a little bit, help them understand the concepts, and just help things get started.
And what is the fee for that when you do that?
$100.
Sure.
Nate,
100, you said?
Hmm.
No.
Yeah,
For your traveling and everything?
yeah. Is that too much?
I don't
No.
think we can afford it
Yeah,
right
that's
now.
too expensive.
But think about it. Does insurance cover? No, Nate. Like really, it's um. How do you handle these things? Hello?
That's it. No, that's it. Yeah, that's it.
So is the purpose mostly to kind of get a word out and train people to understand your philosophy and then um, maybe develop your lab further? Trying to understand the mission. It sounds like
Yeah, yeah.
it's a mission for you.
Yes,
Maybe I'm
yes.
reading it wrong, but okay.
Yes. I mean, I have meetings with people every week almost across the country, even across the world sometimes, people suffering, they had premolars extracted, or that's the only option being given them. We've been to 4 orthodontists, and they all say we have to get premolars extracted. And it's like people don't know that this option exists. And that's my mission is to raise awareness in the public and the profession. Get the jaws forward, open the airway as much as possible. Like, I really believe doing this before the aligners will get the jaws forward more and have a better ending airway result than just doing aligners. But I'm not expecting you to do it every case. Not every person wants to do this.
Mm-hmm.
But I think it's worth having it as an option available.
Yes.
I mean, I've tried to do this on kids and adults who ultimately were not compliant, and then we just did the aligners and just took care of them that way. And I feel like they would have gotten a better result, and I tried, but really, like, it's not worth it if they don't want it for themselves. If they don't see
Correct.
the value, don't do it. I don't want I want you to charge the same thing what you're charging for your liners, but then add on to that. Like, what's your normal aligner fee range right now about?
Right now, we're ranging from like normal case like about 12 to 18 months of treatment with aligners. We are charging about $6,500, and it
Yeah,
can go up to 7 to 75 depending on the complexity of the case.
yeah, beautiful. Yeah, beautiful. So yeah, and I would add to this. So with this, if you're gonna charge 2,000 to get it started and then 300 for a few follow-ups, you're gonna add, you know, 3 or 4,000 to that,
Got you. And
right?
right.
And I also work with another aligner company that, on a small case, my fee is about 250. On a long, like 2 year case, my fee is like 600. A lot of my cases are around 500. So if you want to look at using them for some of your cases, you could as well.
The lab fee for the aligners.
Yeah.
I see.
It's normally about 500.
Wow. Okay.
What's the company name?
And smile,
What smile?
and smile.
And
And
okay.
N is
Yeah, I can send an email introduction.
yeah. Okay. And it does allow you to put those attachments as needed and everything. Like, can you bevel those attachments? I'm like, I've learned Invisalign for years now, and I'm like just so comfortable with that system. I'm a part of
Stay with
their.
that. Yeah, you can stay with that. But yeah, they do attachments on all the teeth.
Okay, good to know. I'm open to look into that, and we go from there.
Yeah. But yeah, if you have a system that's working, you know, staying with it makes a lot of sense.
Right. And how often do they crank the screw, doctor? Every day?
Twice a week.
Twice a week. Okay.
Mhm.
It doesn't matter if they are growing kids or adults, or can you do little faster on the kids?
If we're jumping an anterior crossbite, I'll have them do it every 3 days.
Mm-hmm.
So I have all my anterior crossbite cases, I can share, but that's where we do every 3 days to just get that jumped over as fast as possible.
Okay. And how much, like, with rapid palatal expander, we did get quarter millimeter per turn. How
Yeah,
much
yeah.
are we getting with this?
Yeah, about the same. Yeah,
Same. I see.
yeah.
Okay. Okay. I see. Okay. This is exciting. Exciting. Very,
Yeah,
thank
awesome.
you. Thank you.
Yeah, so tell me, on a scale of 1 to 10, how was learning about this?
Close to 10. Absolutely. I mean, I have not heard of forward growth. I always feel like I'll be blowing the incisors out of the bone, and I've
Yeah,
been very conscious of this, So even working on the kids, planning aligners, I do a lot of buccal, like, like expansion, but I don't do much in the front ever. So this is very exciting to see how much it can do it, and you're literally doing orthopedics right now. You're moving the teeth with the bone. So how beautiful can it be? Like you can't ask for more.
Yeah, yeah, yeah. Wow, no, that's great. Thank you, Dr. Rana. I love that.
Absolutely. This is like, yeah, I mean, we always thought of transverse expansion. We never thought of forward expansion. So this is very like revolutionary concept, especially like this is I think is the true airway ortho.
Yeah, yeah. No, wonderful. Yeah, I love that. Thank you. Yeah, can I share that with other doctors that may be interested in?
Absolutely. Absolutely. Yes. I think now I have full understanding of this patient's mom that I saw this morning. When I saw her, she was so set in having this child treated your way, but I had no idea what that meant.
Yeah,
So I said, I think it would be best if you just go see Dr. Tanner at this point because I, I would love to know more about this appliance, but I don't know how to treat it. If you were to come here, this is how I would treat it. Uh, and she's like, yeah, I would like to get more fee structure and everything, see how your fees are going to be. She was also more fees geared. It looks like she already got a consult from one of the very famous orthodontist here, Dr. Holt.
Okay.
Yeah, so she went there already, and they already talked about the rapid palatal expander and all of that. And she said that the fees were so high that I don't mind going to Oregon and see Dr. Tanner and have him treat my child. And I said, yeah, I mean, that's fantastic if you want to do that, but I'm going to meet him tonight and learn more about his philosophy and appliance, and then let me get back to you. So I'm glad I made that choice and not just give her the treatment plan with the rapid palatal expander and headgear and all of that, and then followed by the phase two.
yeah.
So this is giving me more clarity now. And then I can I can show her
Yeah, let's see
scan
it, please. Yeah, please.
scan to you really quick if you don't mind. That way you get an idea of the case. And then I think we can definitely treat this with
Yeah, because I want you to treat them like they're gonna like I want to support you however I can. But Dr. Rana? Oh, I lost you.
Recording in progress.
Am
Open
I
the
in?
camera. Open the
I can
camera.
hear you.
I'm
Hooray.
so sorry,
Yay.
Nate. Oh, we got
Hooray.
lost.
Awesome.
I'm so sorry. I kind of logged you out while I
No
was in.
worries. No worries. That's okay.
So I can share the screen.
Entire screen.
Okay. This is where is my this is the screen I want to share.
Just share entire screen and then you can talk.
I see.
I think.
Share. And then can you see my screen, doctor?
Oh, yes. Okay. Yep. I see it. Yep.
Awesome. Thank you. So this is Chloe. I have her iTero scan here. The right side is almost class 1, mild class 2 here. On the left side, she is more of a class 3 tendency, and there is a unilateral posterior crossbite here. Mom is very concerned about the crossbite. She understands that's there, and that is her main concern that she wants to address. And if we look at the both arches, it's very like you can see discrepancy big time. There is a wide mandible and like broad arch here, and this is way too narrow in comparison to that.
Mm-hmm. Yeah, and I can see even the lower looks narrow. Looks like the lower laterals may not have enough space.
You're right. Yeah. So in this kind of cases, would you do like an appliance on the bottom as well?
Yeah, I would.
Okay.
Yeah.
So do you use them together, Nate? One on the top, one on the bottom? Is that
Yeah.
so? That's gonna open the patient quite a bit, right? Like how thick is the platform that goes over the molars?
So there's no acrylic over the molars on the lower.
It goes
Oh,
from
okay.
the inside.
Okay.
Yeah, it's just on the inside. Yeah.
So on the bottom, you said you use Schwartz, right?
Yes.
Appliance, okay. And your lab can make that as well?
Yeah, that's right.
Okay.
Yeah.
Okay. So then this is what her case is in a nutshell, and I think I can possibly, I don't know if the pictures are already transferred, otherwise I could show you the pictures as well.
Okay, no, yeah, this is a great case. And we've done a lot of these cross bites, but really it's like the whole maxilla is just underdeveloping and it's
Mhm.
restricted by the upper on one side, restricted by the lower on the other side, and then there's the anterior crossbite. So this patient's just locked in and increased risk for headaches or TMJ issues. Opening this all up would be really, really good.
Mhm.
Yeah.
Okay. All right.
Yeah.
So I could, if the mom decides to stay here, would you be able to guide me through this case?
Yeah. So the mom, so tell me what you decide to set your, you don't have to tell me right now, but tell me what you decide to set your fees at. And mine are going to be 1 or 2,000 higher.
And no, they cannot be free. No.
That's so funny. You're so funny. My gosh, you're an angel.
That's how you collaborate.
Yeah, that is super intelligent.
Yeah.
Okay. Um, I can create the proposal tomorrow and then send it to you, and that way you can take a look at it, and then you can
Let me,
plan your fees accordingly.
yeah, let me look at it. Let me give you some feedback. Let's
Yes,
help there a little bit. And then, yeah, and then I'll let the mom know that we've raised our fees or whatever. Like, I don't know, like what she's saying, but yeah, this is a great case. There's no reason for them to come to Oregon because I want them to send all the referrals to you, not up here.
thank you. Appreciate that. I think this is the area I want to grow in, and oh my gosh, it's like, universe, you keep asking, 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 and then finally, like the prayers are heard, and like you kind of get to meet the person that you have been like. I've been like thinking about this, like who do I go to? I looked at Breathe Institute um, about going and learning airway. I'm like, how do I get more knowledge and possible certification as an airway ortho, you know?
Nate, do you offer, like when you train doctors, can we say we're Tanner certified?
Yes. Yeah.
What does it take to become Tanner certified? Like at what point are you because I feel certified after tonight.
Ah, I love it. I love it.
That was a very easy one.
So we'll go through our training modules and then treat, so many cases, treat 10
Mm,
cases
I
treated.
got
But
you.
for friends and family, treat 5 cases and then you're certified.
10 cases.
I
No, I
know.
got you. She is bargaining.
Uh,
Okay, okay.
She's giving you hard time.
You should be used
yeah,
to
no,
it.
but we want to support you. We want to promote you. We have some brochures that we'd like to give you that you can hand out in the office and in the community and just raise awareness and let people know. I feel like every dentist could do this in their office and help patients and be busy and serve the community.
Absolutely. I agree. I agree.
Well, I mean, there is a lot we can do to help patients, and we already are trying to do that every day. But there is so many myths we have to debunk, and so many like misconceptions that we have to fight every day. That it's like an uphill battle, especially when you have other providers continuing to enable, you know,
Mhm.
certain approaches that may not be as
Yeah,
And
right.
I'm sure you
that
have
is,
gone
yeah,
through that in your journey. I can tell.
yeah.
I'm sure this, like right now, you said how many states, from how many states you're getting the patients from?
20.
Yeah. So, so like I'm sure that just did not happen overnight. I think the this woman that came today with your name, doctor, and the way she presented you, it was, I want to really applaud you on that. That
Oh,
whatever she had heard about you and whatever impact you have created to her family's kids, she is ready to go out there and see you, you know. So that says a lot about you.
So
yeah.
Nate,
Well, thank
is
you.
that why you came to crew at UPW so you can show the cases? Because that's how I met him.
I mean, I love Tony. So I joined because this is a worldwide mission, and I wanted Tony and his team to help me. I wanted to learn how to spread this worldwide.
Get out there, yes.
Yeah.
Lovely, because I did start doing like some of my, like, you know, oral report. I'm trying to create some video blogs and like putting it on the social media. And as I learn more about this, people are listening to it. They are watching it, I can tell, you know. And
Yeah.
I am like wanting to just learn more about this airway. And it's not just about teeth, it's about your overall health, you know. And sleep is such an integral part of it that we are ignoring it. And it's sad that kids also nowadays are so much affected by this. So
Right.
I saw Audrey Yoon's name there too. So do you collaborate with her as well?
I haven't really. I'm hoping to get connected with her more,
She's
but
at Stanford, right?
yeah, yeah.
Yes. Yeah. And she's a surgeon, I believe, right? She's a maxillofacial. Um,
She's an orthodontist.
oh, she's an orthodontist.
Yeah.
Okay. Yeah, that's amazing. She does a lot of MARPI cases, I know that.
Yeah,
Um,
that's right.
so these are some baby steps. I think once I get hang of this, I will look into MARPI as well. I have been wanting to do that for adults.
Mm-hmm.
So do you place your own implants and everything when you offer MRP?
Yeah, we've done Murphy's. Yeah, I placed it.
Is
Mhm.
that where you stick something in the bone and do things?
No, they put you can explain better than I can.
Can you explain just very
MRP,
in a nutshell what is
very,
Marby? He's gonna show me.
um,
It sounds very sexy, but
So here's a patient that came in. So he was narrow. You can see he's a premolar extraction case.
mhm.
So he wanted to breathe through his nose better. We put in his Marpy. He expanded it out.
oh, that's the mark.
So it just opens laterally, creates that space in between the front teeth there. And
So those are implants, right?
yeah, he has 6 implants.
Mhm.
Why would you use this versus
Yeah, so he has six implants in there.
the others? Well, maybe that's a loaded question.
Because the mid-palatal suture is
Yes,
closed,
yes.
right? So you are actually creating like a skeletal anchorage there. You're not using the teeth as an anchor, because if you're using the teeth, you would put the palatal expander here, right? And when you crank up the screw, it would be moving the teeth. But the bone cannot move at this age. The palatal suture is closed, so teeth are just going to tip and get out of the cortical plate. So instead, they put the implants in the middle and they're cranking the screw. So they are slowly opening. Can you open the suture though?
And
At
I use a piezo. Are you familiar with piezo surgery?
no.
It's an ultrasonic
Uh-huh.
that vibrates at a frequency that dissolves bone. So you can
I
see the tissue is just a little whitish here.
Right.
So I did a very, very thin piezo cut through the palatal suture right here.
When you placed the implants and inserted the RP and the MARP,
Yes.
I see. So you disrupted the suture a little bit,
Yes.
and then you start cranking, so then it
Right.
opens. Okay.
Right. And then he's in his Invisalign here. You see the attachments?
Yes.
So he's in his
Mhm.
aligners to closing up the space there.
What if they have a palatal?
And this is holding the bone.
Right. If they have a palatal tori, this won't be possible, right?
Or is it more anchorage?
No, it's possible. No, it's still possible. It's more anchorage. Yeah. No, with palatal tori, like the piezo will still like cut through it.
Got you. So it's a laser that you use to cut through it, right?
Piezo.
No.
Oh, piezo, sorry.
Piezo.
Yeah, I'm gonna show you here. Let's see.
Can we use a laser to go through it? You can totally do it.
Yeah, maybe like a hard tissue laser.
Yeah,
Yes.
CO2.
Yeah, maybe a CO2. I'm not familiar with anyone ever. I've never heard of anyone doing it, but
Got you.
But then
yeah, I could bring my piezo surgery down and let you use it and get familiar with it.
Got you.
Uh,
they're too late. No.
Piezo surgery palatal suture. No, not right now. We don't even have a patient for MARP right now.
I can find you a patient. Let's talk to somebody tomorrow.
Corticotomy.
Tell
Corticotomy.
somebody.
Piezo surgery precisely cuts hard tissue.
so you just do a little cut with a 15 blade,
Uh-huh.
and then you go through this. This is very thin and narrow.
In this photo, you can see that the initial posterior cuts have been made with virtually no bleeding.
You can totally do this. What's
But you just go back and forth along the palate, and it cuts all the way through the palate.
I see.
So I go the whole way through until I hit the mucosa, till I get all the way through the bone.
I see.
And is that helpful? But it's a great, it's very atraumatic and
So you do it the first day when you insert the appliance, do the surgery, and then basically immediately patient will start the next day
yeah,
bending with the screw.
yes.
Okay.
Yeah.
Thank you for showing that.
Yeah, absolutely, yeah. So at some point, you're going to get patients who are interested in that, and I can help you learn how to do those.
Perfect.
Yeah.
This is
Awesome.
exciting. This is
Other
exciting.
cases, we're going to show me some of your Invisalign cases.
Yes, let me
Just don't hang up on him, please.
I am not hanging up now. Yes, you're right.
You're really terrible. Oh no.
Oh yeah, let's
Yes.
just go here. You're right. Thank you.
Oh no, I'm not right. Remember they're gonna close the restaurant when we first met? Now what's gonna be here all the time?
I know. When we first met, we met at a restaurant, and so this is the case that I treated.
Finish the
Yeah, I'm so sorry.
Are you sharing? Are we sharing the screen?
Oh, hold on.
Okay, go ahead.
Okay, share it. Go ahead. Try sharing the screen.
Is this
We're not
working?
sharing it?
Are we sharing the screen right now? Can you see the screen?
No, not yet.
I see.
Which one
Entire.
did you do?
Yeah, the entire screen is.
Okay, so why is it not
Can
showing?
you go Microsoft tab? Yeah, and now my iTero tab and then share. Can you see it now?
Yes. Yep.
So this is the patient. This is actually my first Invisalign first case. Like this is how he started with lots of proclination, severe deep bite. I did the Invisalign first for him and created just room, lots of room all around for the canines here that was very cranked up here. And then on the bottom, there was hardly any room for the canine here. So, and here, and of course, I had to bring this incisor in the position. So, this is the case that I treated with phase 1, and then now phase 2. And this is how his arches are looking.
Oh, wow, that's beautiful.
Yeah. This is what I mean by parabolic broad arches like this. And then if I want to bring them together, this is how he's looking right now. He's almost getting done with the case.
Yeah, that's wonderful. Yeah.
And then I can pull up his pictures too.
Yeah, very nice job on those attachments.
Thank you, doctor.
Yeah.
I don't know how to get Oryx here.
What do you mean? What? How do you open your schedule all the time?
Yeah, it's on a different browser. For the Zoom, it changed the browser for some reasons. I'm here, so
Yes. Can you see that, Nate?
No.
God damn it.
I know. Hold on.
Close your eyes for HIPAA purposes, please.
He can't see it. You're so funny. You can You're good, doctor.
Okay.
That's the most I can contribute to tonight.
Oh my gosh.
You're ready.
Yes, thank you. So here he was when he started his treatment, little Ben. This is how he um, was presented.
I can't see. You have to do share screen again and then
Oh,
choose.
sorry. All right. Sorry. Here. Are you able to see it now?
Oh, yeah, there you go. Yep.
So this is Hugh right here. I think he was about 8 years old when I started his case.
Okay.
I don't have the best picture, but here you can see he was like little retruded and severely proclined maxilla. And interestingly, he didn't have too much like lip incompetence or anything like that, even though there was so much proclination of the teeth there.
Mhm.
Yeah. So this is what he looked like in the very beginning. And now these are the most recent ones. This is you now.
Wow, looking great.
Yeah. Shush picture for him. We're doing it for everybody.
Okay.
And this is his profile.
Yeah, very nice.
Yeah.
Yeah, that's great.
So he's almost getting done with the case now. So
Mm-hmm.
that's him. The other one is similar case, very similar case, similar proclination of the teeth. Like again, same thing. She didn't have as much like when you see this much proclination, a lot of the time that's followed by lip and incompetence and stuff. There was not much of that, but severe deep bite and all of that. And now she is also almost done with the, and I'll show you her scan as well.
Yeah, very nice.
And then if I were to show you her scan, and I'll show you another one that I was telling you about, the deep bite case. So this is her
Oh, I can't see.
before. Oh,
I'm still in the lateral face shot.
got you, got you. I have to change the share screen again.
Mm-hmm.
Uh, Here we go.
Yep.
And this is how narrow she was.
Oh, wow. Yeah, very nice.
No, Vidhi, Vidhi, this is Oshea, another patient. I'll show you. My daughter was one of them too.
Mm-hmm.
It's way severe than this. She was way like almost like V-shaped arch. So this is before, and now this is where she is at. I almost done. I'm closing the posterior open bite now. So she's wearing some elastics and stuff to get that going. Um,
Okay.
but this is her arch development now.
Oh, okay, nice. Yeah, very nice, Arch.
And overjet, it's so funny. Doesn't matter how big of an overjet you start with, at the end, I always fight for the overjet. The mandible just keep coming forward. Can
Yeah,
you like my whole ortho treatment is like overjet, 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 I need overjet. And that's the thing I'm always fighting for. And when I see this much of overjet, I'm like, oh, okay, we have like so much room to grow. And then by the time we are done with the treatment, now I'm fighting for the overjet. I literally burnt all that overjet.
yeah, exactly. That's the thing. Get everything advanced. The mandible wants to be forward.
Correct. Yep. That's what I'm learning. I'm like, ortho for me is all about overjet.
Mm-hmm.
Yeah.
Mm-hmm.
And I know for you as well. So this is another, and then there are some, let's see, what was the name? Can you tell Dharmesh that he's wondering where am I? I didn't tell him.
Dharmesh, this is Dr. K. Hi.
My husband is calling. He's
We're
wondering
nerding out with a colleague. I just didn't want you to worry.
Quentin. Sorry, Doc.
Huh?
So this is another kid I treated. This was a little bit later in his teenage. He was, I think, about 11 or so when I started his case. Can you see the case?
Yep, yep.
He was in crossbite. The laterals were almost in. I think this is the case I could have used. He almost had a class 3 tendency, and
Mm-hmm.
I can definitely use the Tanner's appliance here, I think. So this is how he started the case with. Um,
Mm-hmm.
and then, of course, we treated everything, and then we started him on um, aligners, and then I finished his case in April. And this is
Oh,
how
wow, that's beautiful.
the case.
Look at that, Dr. Rana.
Thank you.
Yeah,
I
well.
wish I had more overjet though. I could not. But this
Mm-hmm.
is
Mm-hmm.
the arch, the way it was developed and everything.
Wow, that's great. Yeah, that's great. I can see why you're so excited and enjoying doing the Invisalign so much. These are beautiful.
Yes, yes. And if I can just add more forward growth, just even 2 millimeter, I'll be happy. And
Yeah, yeah.
that can change the ball game completely.
I mean, even after the aligners, they could go into an airway appliance and just get 2 millimeters and just leave it,
Mm, I see.
so, but lots of options, but these are beautiful cases.
Thank you.
Yeah, yeah.
Yeah, they're taking about a year and a half to 2 years to finish.
Okay.
Yeah,
Mm-hmm. And what's your lab fee on it?
about $1,200,
Okay.
11 to 1,200.
Yeah. Yeah, nice.
Yeah,
Awesome. Yeah, those are great.
and then just one more case, the deep bite case.
Yeah, let's see. Let's see.
Very quick, Chiron. Yeah, so this
Oh
is
my goodness.
like
That's
post.
just like my case.
Yes, this is like your twin brother of your case, the
Yeah.
dental twin. So this is how he is.
Yep.
And
Yep.
then the
Just
lower,
like my case. Oh my goodness. Look at that.
I know, right?
Almost
So when I was,
identical. Wow.
so this is where he is at the start, and now he's way better than where he is now, actually. So this is after finishing the first batch of tray.
Okay. Oh
So
wow.
I proclined, I created the room, um, and now the canines are coming on their own here. And I am now creating more spacing here. I always try to leave more room here, about zero point 0.5, zero point 0.5 millimeters, more than what we have with the primary canines, and then just allow the canines to come in on their own.
Mm-hmm. Mm-hmm.
Yeah. But he is developing more overjet now because, and the deep bite is still needing to be corrected. He is now what, 10 or 11? So the differential horizontal growth hasn't kicked in yet. So the mandible, I know it's coming forward. I'm working on intruding these incisors right now and leveling the curve of spee. So then the mandible can come forward.
Yeah, beautiful. Beautiful. Yeah.
Yeah. So
Do you
that's,
have photos on that case?
yes.
I guess
Uh,
you're still in process. I'm gonna be interested to see, how that looks in another year
mhm.
or so.
Sure.
Or how much longer do you think?
I mean, he's still in, this is him now. Let me show you before.
He still has some permanent teeth to come in yet.
Exactly. So I may give him like a little bit of a rest after this batch. and then again come back after all the permanent teeth comes in.
Yeah, yeah, yeah. Yeah, it makes sense. No, that's looking great. Cool.
He's such a cute kid. I enjoy treating kids is so much fun, I feel.
Mm-hmm. Mm-hmm. Yeah, no, it is. What a joy.
Yes, severe
Um,
inclination.
did your husband do Tony Robbins with you?
Yes, he was there at the UPW with me. Uh,
Okay.
I was in the audience. You guys were part of the crew members, right?
Yeah.
In Anaheim, and I was there with my husband as an audience.
Okay.
Yes.
Oh, wow. So you were okay. So, but you've done all the Tony stuff before.
I'm new to Tony Robbins. Dr.
Okay.
K, Dr. K is all Tony Robbins. I started learning about him a year ago, actually. Last November is when I got introduced to him.
Okay.
I attended his first UPW with Dr. K last. It was a virtual event
In March or so.
in last November.
Last November. Okay. So how did you and your husband like it? Like doing the live one?
It was very energetic, really. Like, I mean, we were very engaged in the virtual events as well, but I definitely see the impact of the live event more. Um, I felt like the sound system was to the point where sometimes the sound was muffling. So sometimes I struggled with what they were trying to say in the auditorium. The sound
Mm-hmm.
kind of
Mm-hmm.
gets a little bit muffled, and I was struggling. Like I had to like really pay attention. But other than that, it was really good.
Yeah, awesome. That's
Yeah,
great. No, I love
yeah.
it. That's
I
great.
love the more networking and like more engaging with the people around you, like you're doing all the exercises with them and you like, what is it called? You share, like, like they give you and then you pair up with the other people that you don't know and then you do the share with them and like kind of like it was weird, like you don't even know the person and you're like literally sharing some very personal things with them, and that
Yeah.
itself is like, like getting out of comfort zone at some point. But that was unique.
Yeah, yeah, yeah. That's great. I'm glad you enjoyed it.
Yes, yes, it was really good. So this one, let me just quickly, I know we all have to go. This is where he is now.
Do your share screen again.
Oh, yes, thank you. Uh,
This is that deep bite case?
yes.
Okay.
So his teeth were like now getting proclined. He has more, let's see. The interincisal angle is improving. The
Mm-hmm.
mandible still needs to come forward.
Mm-hmm. Mm-hmm. Yeah, looking good though. Coming along very nice.
Yeah, his nasolabial angle is improving too. So I don't
Mm-hmm.
know. I have to look in the Ceph and maybe trace some Ceph again, like before and after. I may have to superimpose them and see by doing Invisalign, am I getting some forward pushing, I don't
Mm-hmm.
know. I don't know.
I mean, probably some.
A little bit.
Yeah. Yeah, probably some. Well, it'd be interesting to see because it's like I want what's best for the patient and what makes sense. And sometimes doing my appliance might be more than necessary. It may not get a significantly better result. Sometimes it might. So, like, try it at different
Mhm.
cases and then let's look at the results. Like, share it with me, like, share, there's other people doing Invisalign because like we all want to learn from each other.
Absolutely.
I've
Yeah.
seen some good things with it, but it doesn't mean it's the best thing every time.
You're so humble. That's really nice of you. Yeah.
Yeah.
Yeah. Definitely. And that's why I'm like, with Invisalign, I'm in the clean check. I'm very conscious of the buccal movement of the incisors. I normally keep them where they are. I know I
Right.
don't bring them forward at all. But
Yeah.
still, with the forces of the aligner, they could still be coming forward. I do not know. I think only the cephalometric overlay is the only way to tell whether what I'm getting or not getting.
Right. Because they might be coming forward just a little bit too.
Yeah. Hmm.
Yeah, no, that's true. Yeah, they might. Yeah.
Right.
Yeah, that'd be
But
interesting to see.
yeah, he's showing off his teeth now.
Oh, that's great. Yeah, I love it.
Yes. He's such a great kid. I love him. I've seen him since he was little baby, and now,
Oh my goodness.
yes. And now he has a sister who comes in with her. She's a little baby. Ah, and it's just,
Oh, okay.
but the bite is opening, like he was biting all the way down here
Yeah,
before.
yeah,
So it's slowly, definitely improving.
yeah, way better.
But the way his big smile is, I like where his like lip line is. So now I don't want to intrude his upper incisors more than this. So
Right,
now most of my deep bite correction will be depending on intruding this incisors.
right, right. Yeah,
Yeah,
yeah. Yeah, wonderful. Okay, so that looks great.
thank you.
Yeah, yeah, awesome. Well, I love our shared passion.
Thank you. I appreciate you. It's such a pleasure meeting you today.
Yeah, no, you're welcome. So you're gonna work up your treatment plan and send it over.
Yes.
So sometime next week or something, and then I'm gonna share the cases that we have in Sacramento and give you a heads up. I want to plan a smooth transition, and it's got to pencil out. So I'm not asking for any favors. It's got to pencil out, but just
Hmm.
help provide good care. And we're always available. I want to help support your office and team any way I can at the highest level.
I appreciate you. Thank you so
Do you
much.
have other dogs in our area that you're working with, or
Are we the
No,
first one?
okay?
yeah, yeah.
That's crazy.
Yeah, I have someone down in Southern California who's really desperate to find,
Desperate.
yeah, like a patient.
Oh,
And so I told him about you guys, but it's like it's understandably they want someone down a little closer to LA. So
Right, right.
yeah, so if you know any other dentists that might be interested or open, I'd love an introduction.
Sure, sure. Let me look into that. There are some that I know from my group of Dr. Coddington that I do Invisalign together with, and I will ask them and see.
Yeah, cool. Okay. Yeah.
I'm actually going to talk to Dr. Coddington. Do you know him, Terry Coddington?
No?
No?
No.
Okay. Yeah, I will. Let me do some cases with you first, and then I'll present it to him, and then see if he wants to like introduce you to the whole group actually.
Yeah. Yeah, he might, because like several years ago, I talked to someone with Invisalign, and they said they had an airway study club, and I
Mm-hmm.
emailed my information to them to see if they were interested. I wonder if that might be it.
yeah, you know, Dr. Nolan, that's
It
close.
might have been
Yeah,
a different dentist
She's
at the
all
time.
yeah, she's in
wonder
there
what
too.
she's gonna be thinking.
But Dr. Tracy Nguyen, there is one that is a COIS graduate,
Okay.
but she does a lot of surgical expansions, and on the kids, like
Oh,
MARPy on the kids. And I'm like, why MARPy on the kids? Like, I think we can do, like, even with RPE, you can get a lot of expansion, right? So I found her way of treatment was a little bit too much of an overkill. I felt that there are other non-invasive and ways to correct the, like your case, the way you are treating is non-invasive. It is still a good expansion that we are getting, and the results are the same whether you do surgically or non-surgically. So why go surgery, right? That's
right.
on
Yeah.
the kids. Like, you don't want to traumatize them at this early of an age.
Yeah.
So that's what I found. There are some treatment modalities, like we saw, there are some doctors who joined and they shared their passion, but I I felt like I found more aggressiveness into that.
Yeah. Yeah.
But your presentation is very genuine and I can see how it's working and everything. So I'm very
Mhm.
excited.
Yeah. Awesome. Awesome. No, that's great. Well, I love it. I look forward to getting to know you more and working together with you both.
Thank you, doctor. Thank you.
Yeah.
Likewise.
Thank you, Nate, so much for taking the time, and Dr. Rana
Yes,
too. Thank you.
absolutely.
It's way past my
I
bedtime,
know.
so so Nate, I mean,
Okay.
See
Bye.
you. Bye.
Happy
Good night.
Thanksgiving.
Happy Thanksgiving.
Happy Thanksgiving.